Okay, great. We've got a good topic today to cover. We're going to talk about some granulomatous dermatitis, which is a pretty important field. We actually see a lot of biopsies for this. So when dermatologists see something in the dermis that feels firm, they take biopsies of it. They want to make sure they're not dealing with something serious. So um, we get a lot of biopsies of things that are granulomatous. And so we're looking at granulomatous dermatitis. There's 5 patterns of histologic granulomatous inflammation that you need to know about. So hopefully you guys either know that by heart. If you don't, you need to learn it by heart. But basically, there's palisaded, there's the sarcoidal, there's tuberculoid, there's foreign body, and then there's suppurative. So we have all those 5 patterns that we see under the microscope. And so when you look at granulomatous inflammation, we define granulomatous inflammation as histiocytes predominate, at least focally, in the infiltrate. And so when you see that, you can get it into one of those 5 categories, and then you can come up with a specific diagnosis. And probably one of the most common that we see is this pattern, which is palisaded granulomatous dermatitis. And it's kind of fun to teach this concept because there's 3 main palisaded granulomatous dermatitis. There's granuloma inulare, there's rheumatoid nodule, and then there's necrobiosis lipoitica. Those are the 3 most common. And when you think about palisade, if you go back in time to the days of Davy Crockett and Daniel Boone and Fort Ticonderoga and all that kind of thing, they basically, a palisade refers to the picket fence, if you will, the spikes in the ground that go around the fort. So if you look at a palisaded granulomatous dermatitis, you're going to think of this as the little logs with the sharp points on the outside that are sitting around here. And then the center is where the guys would hang out with their families, and the military would be in there, and they'd be protected from the Native Americans out here, and they're inside the fort here. So they're all safe when they're in here. And I think that another term that I remember Dr. Al Kopf at NYU years ago when I was a resident introduced this term to us, and he called it, you call these palisaded granulomatous dermatitis the thesaurusmoses. And thesaurus, which you guys may or may not know what it is, but in the old days, we used to have Roget's thesaurus. So if we were looking up writing a paper, we'd have to look up a synonym or in a word. We get out the thesaurus and look it up. Well, now you just go on Google and quickly it'll give you a synonym. But in the old days, you'd have a thesaurus. I think they may even call it a thesaurus still on Google. But the actual word thesaurus comes from the Greek word that means treasure. And so a thesaurus is a treasure chest. And it was given that name because if you had all those synonyms of words and you're writing a paper, you just pull out the little treasure chest to get the word that was just perfect for your sentence. So you can think of a thesaurusmosis as being a treasure chest, and what's in the center of the treasure chest, as you can ask yourself. And in granuloma inulare, it's mucin that's in the center of the treasure chest. And so you can see this is all mucin. It's grayish granular, grayish blue granular. It's basically hyaluronic acid. It's ground substance that's produced by fibroblasts and histiocytes, and mast cells produce dermal connective tissue mucin. And so this is granuloma inulare, which is a classic pattern. And then in the center of the palisade of rheumatoid nodule, which we're not going to look at today, you see fibrin. And then in the center of the palisade of necrobiosis lipoitica, you get degenerated collagen. So depending on what's in the center of the palisade, you can make an accurate diagnosis. Now, I'll just tell you that in some cases of rheumatoid nodule, you can see some mucin. In some cases of so-called subcutaneous GA, pseudo-rheumatoid nodule, you can see some fibrin, and the patient doesn't have to have 1 iota of rheumatoid disease. So there's some overlap here. And you can sometimes get some degenerated collagen in the center of granuloma inulare. But just remember that this is the general pattern, and if you use this, it works well. Now, there's several different forms of granuloma inulare. There's the so-called interstitial mostly form, where you get the histiocytes kind of splayed between among collagen bundles. You get the nice ring of histiocytes like we see here. So this is a beautiful example of classic GA. And then you can get other subtypes of GA, like I mentioned before, the pseudo-rheumatoid nodule, subcutaneous GA. You can get perforating GA. So there's several different histologic and clinical subtypes of granulomedullary. This is a classic example of that. Just a couple other pearls about GA. There are some simulators of it other than the typical other palisaded granulomatous dermatitis. You always have to think about, at least briefly, the possibility of epithelioid sarcoma, which simulates GA. It's really a neoplasm where you get central tumor necrosis and you get a palisade of actually neoplastic cells that are highlighted both with cytokeratin and with vimentin. And then there are the granulomedullary-like eruptions that occur in patients that have connective tissue disease, so-called interstitial palisaded granulomatous dermatitis. And those can be associated, usually don't have as much mucin, but they can have some mucin, and they also can sometimes have some neutrophils in there. And if you see GA erupting in an older person, you should always think about the potential that it might be a perineoplastic process. So that's GA. Now moving on, we're going to talk about another type of inflammatory reaction, and this isn't really a classic granulomatous dermatitis. It's what we call Xanthogranulominous inflammation. So here we have lots of histiocytes, but we also get large other kinds of multinucleated histiocyte-like cells in this lesion. And this is a xanthogranuloma. So we're talking about xanthogranulomatous inflammation. The xantho means lipid, so you'll see lipid-laden histiocytes, plus possibly epithelioid histiocytes. And if you scroll around, you'll start seeing some two-ton giant cells, cells that have multiple nuclei in them. And they'll often have two tones of cytoplasm. You get the cytoplasm that's got some lipid in it, like here, and then you get that kind of amphiphilic cytoplasm in the periphery. So this isn't typical granulomatous inflammation, but it is in a process associated with histiocytes. So it's quote granulomatous, if you will, and it's what we call xanthogranulomatous inflammation. And there are a whole group, family of these non-X histiocytoses that I would recommend at least spending a little time with. You don't have to become an expert on it, but you do need to know these various entities that give you the xanthogranulomatous inflammation. So xanthogranuloma associated with, and it can be associated with systemic illnesses, juvenile AML. It's also been associated with neurofibromatosis. So make sure you're familiar with that. You can also get xanthogranulomatous inflammation associated with some of things like progressive nodular histiocytosis and generalized eruptive histiocytosis. Those are some of the non-X histiocytoses, so make sure you're familiar with some of those. You can get xanthogranulomatous inflammation in necrotic xanthogranuloma, which we're not going to look at today, but that's yet another situation. And here you can see some of these cells that have that lipid-laden cytoplasm, as well as the two-ton giant cells. You can also get xanthogranulomas occurring in adults. They don't have to be seen only in children, even though we call it JXG. And if you get an early lesion, they're often associated with a lot of non-granulomatous inflammation. You get a lot of eosinophils in an early proliferative XG before it has a chance to make the two-ton giant cells. Okay, let's take a look at this one. And we've got a punch biopsy. It's got some artifact. The epidermis is kind of sheared away from this, so don't pay attention to that. We're really going to focus mostly on the dermis. And notice that it's got this very dense, diffuse nodular infiltrate here of these pale cells. So whenever we see something in low magnification with pale cells, I want you to think of granulomatous inflammation. So low power, pale cells, at least think of granulomatous inflammation. It may not be your higher magnification. It could even be a neoplastic process, but I always want you to at least think of granulomatous inflammation. So here, this is basically just an artifact. This normally wasn't really a blistering process. This just got sheared off in processing. But notice now we've got multiple nodules of these pale staining histiocytes. They're forming small epithelioid granulomas. And what do we mean when we say epithelioid? It means it looks like an epithelium. So we talked about epithelioid sarcoma a second ago. That's a sarcoma that looks like epithelium. So here we've got epithelioid histiocytes forming these little small epithelioid nodular granulomas, and we refer to this as sarcoidal granulomatous inflammation. So we've seen palisaded, we've seen that xanthogranulominous pattern, and now we're looking at sarcoidal granulomatous inflammation. Now, what's the most common cause of sarcoidal granulomatous dermatitis in the skin? Well, obviously it's sarcoidosis, and when you see something that's got this very dense nodular infiltrate with all of these sarcoidal granulomas, it basically almost formed a syncytium of granulomatous inflammation. That would be the number one diagnosis that you would think about. But there are other conditions that give you sarcoidal granulomatous dermatitis. So other things to think about. One of the most classic ones is tuberculoid leprosy, tuberculoid Hansen's disease. So again, that's a situation where, you know, it's tuberculoid, which you think of, well, gosh, if it's tuberculoid, it's going to give you a tuberculoid granulomatous inflammation, which means you've got degenerated caseation degeneration of the granulomatous inflammation and also the collagen in the center of the granuloma. It's not really palisaded. It's basically granulomatous inflammation where you get degeneration of the histiocytes. But no, it actually gives you sarcoidal histologic pattern. So tuberculoid Hansen's, sarcoidal granulomatous inflammation that's usually elongated and goes along where the nerves are present in the skin. It goes along the neurovascular bundles. Silica, from somebody that gets in a car wreck and gets some glass in their skin, or some of the other metals, heavy metals like beryllium, zirconium, some of those things, those can give you also a sarcoidal granulomatous dermatitis. And sometimes patients that have sarcoid get an injury, they'll get in a car wreck, they'll get glass in their skin, and they get sarcoidal granulomatous dermatitis. And guess what? They may actually have sarcoid that shows up when they get injured, because sarcoid tends to Kebnerize at the sites of injury, or it may actually, in some cases, precipitate sarcoidosis. So it's an interesting situation there. And you always want to polarize granulomatous inflammation when it's sarcoidal like this to make sure you're not dealing with something like silica or something like that. And then we also see sarcoidal granulomatous dermatitis association with tattoo reactions. Lots of people get tattoos today, and especially the vegetable tattoos, when they get the tattoos that contain vegetable-like material, or they contain plant-based dyes. People that get their eyebrows tattooed or their eyelids tattooed, eyelashes, those very commonly will give you a sarcoidal granulomatous pattern. So this is a nice example of sarcoid. We always talk about sarcoid giving naked granulomas. Well, I always like to say that it's sort of almost like they still have their underwear on a little bit. There's usually a little bit of lymphocytic infiltrate in there as well. Sometimes it's purely granulomatous inflammation with no lymphocytes, but here there's obviously some lymphocytes as well. One last disease that can sometimes give you sarcoidal granulomatous dermatitis, not usually this intense, tightly packed granulomas, but syphilis, obviously. Syphilis can do just about anything, and it can give you a granulomatous dermatitis. Always remember, the granulomas of syphilis tend to be poorly formed, but sometimes they can look sarcoidal like this. So this is another example of it's sarcoidal granulomatous dermatitis, and in this case, it was due to sarcoid itself. Okay, another pattern that we see. Notice it's kind of got a dense, diffuse infiltrate here in the dermis, mostly in the lower part of the dermis. Upper part of the epidermis is relatively spared. And we've got now granulomatous inflammation. You've got some degeneration of collagen. You've got some structures here that look like they don't really belong in the skin. You might even have some little bubbles in the skin here. So this is an example of a foreign body granulomatous dermatitis. I'm not sure exactly what the foreign substance was here, but it's got these little small bubbles in there, so it might make you think that it might be silicone. So silica is the crystalline molecular form of silicone. It's a silicate, obviously. It's got silicon dioxide. Silicone is the actual element of silicone, Si. And so when you patients get, silicone injections for wrinkles and things like that, it's supposed to be industrial grade, very pure silicone that gets injected. And theoretically, it shouldn't really induce much of an inflammatory reaction. If you look over here, there's some black material here. So there's some carbon. So this might be a situation where somebody got maybe something injected in their skin to try to improve their cosmetic appearance. Maybe it had non-industrial grade silicone and it was perhaps maybe contaminated with carbon and some other things like that and induced this granulomatous reaction. One other thing to look at here, this isn't quite as good of an example as we see in some, but whenever there's a little line like this, that's drawn across through the skin, like in the biopsy like this, that's an artifact from the knife blade that is cutting the tissue. And when it's a linear thing like this, it suggests that there may be something foreign here that the knife just kind of dragged through the tissue when it was cutting the section. So that's a clue that there's something foreign in here that's getting kind of dragged through this tissue. So that's not just an artifact from the cutting, it's an artifact because there's probably something in the tissue that got pulled through when they actually made the section. So that helps you to suggest that this is probably, and you can see another one over here, a foreign body granulomatous reaction due to something that was exogenous. So again, if you see little tiny bubbles, think about silicone. If you see little crystals in the skin that look like little pieces of glass, tiny glass shards, think of obviously silica. If you see something that looks like little needles, think about the possibility of fiberglass. We see iron containing foreign material. We see plastic containing foreign material, carbon. So, patients get injured and they get things in their skin. We see splinters, very common source of a foreign body reaction to the skin. So that's an example of a foreign body reaction. And notice that the pattern is not, it doesn't have those nice tight sarcoidal granulomatous pattern. It's got kind of a mixed pattern with some dilated, some large histiocytes, epithelioid histiocytes, and even some neutrophils in some areas. Okay, we're looking now at case number 5, and this is a different pattern. I'm going to show you the central area right over here. And let's look at this. And now we've got a suppurative granulomatous process. It's involving the upper part of the dermis a little bit. These are histiocytes, so again, it's granulomatous. And then let's look down at the bottom near the fat. Again, notice we've got this inflammation that's tracking down in here, and now we've also got some suppuration. So we've got neutrophils, we've got lymphocytes, we've got histiocytes, and so we've got a suppurative granulomatous dermatitis. And we see suppurative granulomatous dermatitis, the most common of that, and here we've got even suppurative granulomatous dermatitis and paniculitis. The most common pattern of that is due to rupture of folliculitis or rupture of a cyst. So by far the most common suppurative granulomatous pattern in the skin, even though it's a foreign body reaction, but it's giving you a suppurative granulomatous pattern, is ruptured folliculitis. The second most common is probably some type of an infectious process. And especially if you see, not in this biopsy, but if you see like abscesses, epidermal hyperplasia, small areas of pseudoepitheliomatous hyperplasia, that is a very, very common pattern for an infection like a atypical mycobacterial infection or a deep fungal infection, something like that. So suppurative granulomatous dermatitis with pseudoepitheliomatous hyperplasia with abscesses, transepidermal elimination organisms, things of that nature. Think about one of those kind of infectious processes. If you see something like this, this was one that we signed it out as a suppurative granulomatous dermatitis, possibly an infection. Special stains were done in this case. And about 40 to 50% of the time when you do special stains in something like this, they'll be negative. It's obviously nice when it's positive, but unfortunately, they're often negative. And usually they're negative because by the time you get prominent inflammation, the host reaction pattern is coming in and it's killing most of the organisms, and there's not very many left. And so you can't really see them very easily. You have to look at it, search really hard. So you may not even find them, no matter how hard you search. So the better technique is obviously to do cultures. We also have other techniques available to us today. We use PCR in some cases. We use, immunoperoxidase stains. So Serology, don't ever forget about doing serologic studies. Those are things that dermatologists sometimes forget. They sort of get biopsy, tunnel vision, but there are other techniques that are available that can help you make a diagnosis other than doing a biopsy. So if you don't find the organisms, think about other techniques and don't just leave it at that stage. So think about getting an acid-fast bacterial infection, maybe quantiferin gold or a PPD, something like that, and even say AFB. And it's not tuberculosis itself. You can get some cross reaction if it's one of the atypical AFBs in that situation. Okay, let's take a look at this one. This is another very common thing we're kind of seeing today. This taken from areas got a lot of, no, it's not really showing the pattern. Ah, yeah, here it is down in this area. Beautiful. Okay, good. So notice, I'm not sure what part of the body it's on, but it's an area where there's a lot of muscle and there's some sebaceous glands here. So it looks like it's on volar skin when you first look at it. You say, gosh, look at all that thick cornified layer. It looks like it might be from near palm or sole, but no, it's not near palm or sole. This is actually because the person is rubbing it. And how do I know that? Well, because you have hair follicles here. Whenever you have hair follicles plus a markedly thickened cornified layer, there's really only two conclusions. One, you're dealing with a gorilla where they actually have hair follicles in their palms and soles still, or you're dealing with lichen simplex chronicus. And so we've got that in this situation. The person was rubbing the area. They didn't like what they were feeling here. And what is it that they didn't like? Well, look at this area over here. We'll go up to the top one. They've got all of this stuff down in the subcutaneous fat. And notice these little tiny bubbles again here. So I just mentioned this to you before. This is silicone. Silicone, this is a beautiful classic example of a silicone reaction. And normally silicone, it'll give you a little bit of fibroplasia, maybe a little bit of inflammation. Here you've actually got some granulomatous inflammation. So this probably was a silicone foreign body reaction. They probably had a lump in their skin. They probably started saying, hey, I don't like this here. I'm going to start rubbing in and feeling in and whatnot and trying to get rid of it. There's also a couple of other things over here too. Notice that there are these little small little BBs in the skin. So this is probably 2 fillers I would imagine. And you know, patients that get filler injections, they want to look pretty. So they're getting all sorts of stuff. They may get endogenous fat injections. They may get hyaluronic acid. They may get methyl methacrylate injections in their skin, Juvederm. They may get Radiesse. They may get all sorts of things injected. So this is not methyl methacrylate. This is silicone over here. These small little tiny bubbles, that would be silicone. These little BBs in the skin that they're not blue and calcified would probably be like one of the methyl methacrylate coated little BBs here. And some of those actually, they can have a lot of things inside the center of those. They can have collagen in there. They can have calcium hydroxyapatite. So depending on the filler, they can look kind of like these little BBs. So this looks like kind of a combination of 2 different fillers. But notice it's mostly granulomatous. There's not a lot of suppuration here. And but it did cause a granulomatous reaction. And they took a biopsy. And notice how deep this is injected. This is all the way down into the area of the muscle. And that's where a lot of these, some of these fillers do get injected relatively deeply in the skin. So you kind of need to know your fillers. And the hyaluronic acid fillers look more like blue-gray jello in the skin. They look like little angulated bluish-gray collections of gelatin. And that sort of makes sense because gelatin is basically hyaluronic acid in many ways. So there's a component of that that's in when you're looking at hyaluronic acid filler injections as well. But this is more like silicone, possibly with some methyl methacrylate coated beads that were injected here. Okay, another pattern. And this is one of the more common biopsies that we get. And the reason we get it is because somebody wants to rule out lupus. And so this is taken from the face. It's got a perifollicular granulomatous inflammation with some lymphocytes. And maybe in this area, yes, we have a nice example of tuberculoid granulomatous inflammation. So this is a nice example of that. We've got these histiocytes that are somewhat epithelioid with lymphocytes surrounding it with degeneration of the granulomatous inflammation centrally. Now, when we think of tuberculoid granulomatous inflammation, we tend to think of tuberculosis. We think of the tuberculids, we think of the some of the atypical mycobacterial infections, we think of the class of tuberculosis itself can give you that pattern. It can be seen in other infections too, but probably the most common setting where we see it today is in Granulomatous Rosacea. And that's exactly what this biopsy is of. It shows the tuberculoid pattern of inflammation that we see with Granulomatous Rosacea with a lymphocytic infiltrate around it. Very common pattern that we see with rosacea. And this is not suppurative granulomatous, at least in this field. Now, you can get suppurative granulomatous dermatitis with rosacea because you can get folliculitis, it ruptures and whatnot. But when you see this pattern, this is the classic pattern that we see with this pattern with lupus miliaris disseminatus faciae, with just what we call granulomatous rosacea of somebody's face. When you biopsy it and it looks papular and yellowish, you biopsy it and it shows this pattern. So this would be a nice example of granulomatous rosacea. Now, one other thing about rosacea, sometimes you can see sarcoidal granulomatous dermatitis there. It can simulate sarcoid. So just remember that from a clinical perspective. But here, it's got this beautiful example where we've got the tuberculoid granulomas. One other thing about rosacea is sometimes if you biopsy, you may not see any granulomatous inflammation or suppuration of the follicle. You can get a lymphocytic perifolliculitis and a lymphocytic infiltrate that can be photoexacerbated. And so guess what? People biopsy rosacea to rule out lupus. You don't want to overcall it as lupus. We see a lot of that where people will call this pattern over here without the granulomatous inflammation, calling it consistent with lupus or lupus. And then the patient, once they get a diagnosis of lupus, it's like the scarlet letter L that's branded into their skin. They carry it around with them forever. And they think that they have lupus and they tell everybody, I've got lupus. Well, they don't have lupus. Many of the times they just have rosacea, and it doesn't do the patients any favors if they have to go on Plaquenil and get problems with that or whatever, or they get their insurance get dinged because they think they have systemic LE, when really they just have rosacea. So just remember that rosacea can simulate lupus both clinically and histologically, but generally it's readily distinguishable in most cases. Now this, I mentioned this before, I'm glad we have an example of it here, is also kind of going back to the palisaded granulomatous dermatitis. And notice that when we talk about palisade, sometimes the picket fence is really nice and round and it's really well defined. In other cases, there's more of a diffuse pattern where you don't get the nice little rings in the skin. And that's still palisaded granulomatous dermatitis. So when we see interstitial, mostly granulomatous inflammation, that can be seen in GA. We refer to that as kind of forms of sort of like an incomplete, poorly formed palisaded granulomatous dermatitis. And when you see that, you should also think about this so-called palisaded granulomatous dermatitis associated with connective tissue disease. And when you do see that pattern, you'll often see neutrophils in the infiltrate. And here you do see neutrophils admixed with it. It's got it does have some palisading here, but it's more interstitial. So interstitial, with or without mucin. If there's mucin, it's great, but you don't have to have much mucin in this. With neutrophils, you should think about this disease. And we used to think that this was associated with rheumatoid arthritis. And the first cases that we saw, that we described in the 1980s, was seen mostly in rheumatoid arthritis. But now we know you can see this in lupus. You can see it in like mixed connective tissue disease on occasion. Less common to see it in the morphea scleroderma diseases, but any kind of lupus, rheumatoid arthritis, things of that nature, you can see this pattern. So this is not specific for rheumatoid arthritis. Less common to see with dermatomyositis, but now there's probably about 4 or 5 different subtypes of dermatomyositis. So if I saw something like this, I wouldn't just say, the patient's got, palisaded granulomatous dermatitis associated with rheumatoid arthritis. I'd want to make sure they didn't have lupus or something else also here. So important to make sure that you know what disease your patient has. And these can present either as kind of ill-defined, urticarial appearing plaques in the skin that don't go away, they come and stay. It's not urticarial vasculitis, there's no vasculitis here, but they also can present as a linear rope-like lesion, a cord-like lesion in the skin, and this is not a cord that's down in the blood vessels in the subcutaneous fat running in that area. These are actually in the dermis, but they can give you a linear pattern, which is kind of fascinating. You get a granulomatous dermatitis with a linear clinical appearance. So this is the palisaded interstitial granulomatous dermatitis associated with connective tissue disease, not necessarily rheumatoid arthritis. Okay, here's another example of granulomatous inflammation, and this is seen on an area where there's a lot of sun damage here. And so we've got lots and lots of histiocytes here. They're multinucleated. There are all these elastotic collagen bundles. They're engulfed by these histiocytes here. So what's the diagnosis in this case? Well, in the old days, and I think some people even in the new days still call this actinic granuloma. And basically what this probably is, and I don't have any definite proof of it, but the way I was trained is that it's probably a variant of GA occurring in an area where there's just a lot of sun damage. I don't know for sure if that's true. It could really be that the elastic fibers get damaged by solar alteration, they become immunogenic, and then the host comes in there and puts in all these multinucleated histiocytes, starts engulfing them, and then you get a granulomatous inflammatory infiltrate. So, but this is what, if you see actinic granuloma, this is what it looks like. It basically shows these histiocytes that engulfed all these elastic fibers. Now there's a couple other diseases where you can actually get engulfed elastic fibers with large numbers of histiocytes. One of them is so-called granulomatous slack skin syndrome, which is associated with cutaneous T-cell lymphoma. And you can get large multinucleated histiocytes like this that can engulf these cells. And then there's another situation, which is rare, but does happen on occasion, and that's acquired cutis laxa associated with monoclonal gammopathy. And we saw a case of this a number of years ago that the biopsy looked very much like granuloma annulare. In fact, we originally thought it was GA when we did the original biopsy, and it turned out the patient started getting the bloodhound-like facies, her skin started drooping. They actually did an immunofluorescence on it. There was IgM that was coating the elastic fibers, and then there were these histiocytes were coming in and engulfing the elastic fibers, and then she's getting this horrible atrophic cutis laxa from the monoclonal gammopathy, which cutis laxa is associated with monoclonal gammopathy. And if it gives you that pattern, that's really what you see, is because of the granulomatous inflammation that comes in secondarily to these opsonized elastic fibers. So this is what you see in actinic granuloma. If you're more of a lumper like I am, I sort of tend to think of this as just a variant of GA on solar altered skin, but at least realize that there is a form of this granulomatous inflammation that comes up on severely sun damaged skin in some individuals. Okay, look at case number 10, which is one more or one after this, but this is another situation where we see granulomatous dermatitis. And sometimes, you know, remember granulomatous inflammation, it also can be a reaction pattern. So when it develops in the setting of an infection, obviously it's a secondary phenomenon. It's not a primary disease. When it comes up, like, for example, with sarcoidosis, well, then it's a primary granulomatous disorder, you know, GA, NLD, those are primary granulomatous disorders. But in other cases, it comes up as a consequence of another infection or some other process, like a foreign body gets injected, like we talked about before. You get secondary granulomatous inflammation from rupture of folliculitis. So you have to ask yourself, you know, is this primary related to the disease itself, or is it secondary to something that's going on in the skin? And there are lots of different things that can induce granulomatous inflammation, like we've talked about. And one that's not super common, but we see on occasion, is when you get a post-herpetic infection. So herpes can give you lots of different things that go on in the skin. You get the obvious, you know, blisters with the acantholytic and ballooning cells in the epidermis. You can get vasculitis, you can lichen inflammation, you can get an inflammation where there are a lot of eosinophils, and then sometimes you get a post-herpetic granulomatous reaction that looks like this. It's kind of a non-specific infiltrate of just histiocytes in the dermis with scattered lymphocytes. It's not, doesn't really look palisaded. It's more almost kind of just diffuse infiltrate with some of these epithelioid and some multinucleated cells. So again, we didn't know that this was granulomatous dermatitis related to herpes virus infection when we first saw the biopsy. But when we got the clinical information that the person had a classic case of shingles and it went away and had these lumps that developed, they took the biopsy and lo and behold, it showed this pattern. Now, I don't know if the patient had an underlying sarcoid or something like that or just developed, but we do know that in some patients that have herpes infection, heals can give you a granulomatous inflammation, can also give you a lichenoid inflammation here. There's almost a perifollicular lichenoid infiltrate here. So herpes can do all sorts of weird things. So just remember that you may see a granulomatous dermatitis that's persistent in patients that have post-herpetic inflammatory reactions. Okay, the last one we're going to look at today is this one here, and I think it goes like this. We've got a very diffuse infiltrate here. Notice that a lot of these cells are pale at low magnification. So once again, you think of histiocytes, granulomatous inflammation. Very dense, diffuse infiltrate involving all the dermis. So everything is involved here. And it gets all the way down to the subcutaneous fat. So we get dense, diffuse infiltrate with lots of histiocytes. And in this situation, you start looking at the histiocytes themselves, and they have a very clear staining cytoplasm. Once again, histiocytes tend to have abundant cytoplasm. Well, this one's got massive amounts of clear cytoplasm. You start looking at it, it's got some kind of almost granular bluish gray morphology to what's sitting inside these individual histiocytes. They're filled with lipid, and they're lipid because these are not just, this isn't just cholesterol or triglyceride that's inside these cells. These are actually lipid-laden microorganisms. And when you get this many cells like this, these are the so-called Virukov cells of Leprosy or Hansen's disease. And this is a very multibacillary form of the disease here. It goes all the way down into the subcutaneous fat over here, as you can see. Maybe this should have been oriented at 90 degrees. Maybe we'll go that direction for you, but sort of doesn't make any difference because basically no matter where you look, top to bottom, side to side, it's just loaded with granulomatous inflammation that contain all of these cells in it. So this is what I want you to recognize, is that these are the so-called Virukov cells, not Virchow, it's Virukov. It was a pathologist back in the 1800s who looked at this under a primitive microscope and recognized these in patients that had leprosy. And I'm not sure they knew what they were at the time, but they knew that this was associated with bad disease, and they actually had Hansen's disease. So if you look at this under the with a special stain for phyte stain, it just lights up like a Christmas tree. So everything in here, all of these cells are just filled with these organisms here. And these are called globi. Now, what are globi? Well, basically they're sort of like the little, see the Native American chief on the old cigar stores carrying the little things. Well, those are the globi of the cigars. So these aren't cigars, these are microorganisms that are forming these little clusters of organisms inside these lipid-laden histiocytes filled with Mycobacterium leprae. So this is multibacillary Hansen's disease, polar lepromatous, not borderline, not tuberculoid. This would be really polar lepromatous disease with millions and millions of organisms in their skin. So, so that's an example of some various patterns of granulomatous inflammation today. Again, get familiar with these patterns, know the 5 different patterns of histologic granulomatous inflammation, know the diseases that cause most of these, and you'll be able to make more specific diagnoses, and you'll be able to ace your board examinations. So thanks for your attention today, and we will see you on the next time. Take care.